Hello friends, today we'll be discussing something related to the medicine paper 1. We are talking with respect to RJHS, that is the Karnataka University. So if we go through the portions which is there, so we have a cardiovascular system comprising for 19 marks, then we have endocrine totally for 25 marks. I'm just clubbing hypertension also under endocrine. So rheumatology for 6 marks and toxicology and immunization for 12 marks, the GI part for 15 marks roughly, and nutrition and obesity for 10 marks, and pharmacology and general for 10 marks. So totally it might comprise up to some 100 marks. So this is the maximum marks which they can ask. So based on this, we have formed an kind of prediction, uh, so that it is useful for all of us. So what is the basic idea behind this prediction is, see, both LAQ and short essay questions can be predicted to some extent, which will fetch you about 60 marks. Okay, but 3 marks itself, the nature of 3 marks itself is always kind of unexpected. So the aim here, what is that? The aim here is they test your paraclinical knowledge and third year knowledge. So this topic itself is highly variable, so make sure you know these things, but I don't guarantee any kind of questions in this part. But for 10 marker and 5 marker, for sure you can say. See, for example, one question from CVS. So let us club this 10 marker question where you can score up to maximum of some 16 to 18 marks. So there are only three major topics which you need to study. That is CVS, endocrine, and hepatobiliary with GIT. One time they have asked even about OP poisoning, but the nature of OP poisoning is something like which you are studying from second year. So and also I would like to make a point that whenever you are studying 5 markers, prepare it for even for a 10 marker question, so you know how to elaborate it well. So these topics, when you are studying, make sure you study in depth. So in these topics you need to have an in-depth knowledge. So next, let me go to the short essay question. So diabetes is for like 5 marks. So usually from past 2 years, these are the questions which are being asked, that is management of diabetic ketoacidosis or HHS. Okay, so you should the management part, which I made notes, so that we will discuss in the subsequent classes. The next part, which the next part, which is quite of predictable, is the forensic questions which they have asked. So it might be something related to the medico-legal case or negligence, and also about the euthanasia part, which they had asked in previous exams. So that kind of question is kind of predictable in the forensic part of this medicine paper. So next part, which the next part which is there, is the endocrine part. The nature of this question is not predictable, is predictable provided if this comes as a 10 marker, but it's not predictable if it's not a 10 marker, because there is a variety, there is a lot of options which you have. So basically, whenever you are focusing on endocrine, the first thing, I'm leaving diabetes because diabetes is sure question for 5 mark, nobody can say no for that. But whenever you're studying endocrine for 5 mark, make sure you know the thyroid part well than the Cushing part. Okay, Cushing is usually asked for 3 markers, but you can definitely study Cushing for 3 markers. But also have some knowledge on how to expand it for 5 marker, but you should have a sound knowledge about thyroid disease, both hyper, and also thyrotoxicosis thing. So there you need to have a sound knowledge. So that is what I want to say with respect to endocrine, and also in and out of secondary hypertension. Invariably for 10 marks or 5 marks, you will get a question on secondary hypertension. Make sure you know that very well. That's what I even written in the CVS part. So you can consider it in either endocrine or CVS. And also, if in CVS part, if you are not gotten the heart failure thing there, you can get an heart failure thing. So these two questions, though it is parts of pediatrics, make sure you have a knowledge about that. And also the other part, for example, the criterias and TOF, something related to that, make sure you know something about that. The next question, which is kind of predictable, is the toxicology part. So this is something to do with the third year MBBS, where you are studying from forensic medicine. So the major question which they ask is OP poisoning, paracetamol poisoning. These are the two major questions which they ask. they might change the question, but make sure you learn this properly. Okay. And rheumatology is something which is consistently asked for 5 marks. The major question which they have asked is RA. Make sure you prepare for SLE and also some criterias. Okay, for example, ACR ULR criteria and criteria for SLE, and a few kind of 3 marker questions also be ready for 5 marker. So rheumatology is, that's it. Then also the nutrition part, this is something which all leaves a day before exam. You should make sure that you know the doses of all the vitamin deficiency, for example beriberi, and for niacin, how much ever you have to give. And also the obesity related part, they ask you about classification, definition, types. So make sure you know about that. The next part which we are going to discuss is about the hepatobiliary. So if the cirrhosis part of liver is not asked, the most predictable question in hepatobiliary for 5 marker is hepatitis, that is viral hepatitis than cirrhosis, though both can come. But in GI, if you can expect the acute bleed kind of questions. Okay, this is what so this almost makes up to your 60 marks. So I'm not saying you all the 3 4 8 10 questions. So all the 10 questions might not be the same thing, but at least 7 to 8 question out of this 10 question will be almost sure or follow the same pattern. What do you mean by same pattern? It will be something related to the topic or the particular topic itself. So make sure you study this part. And what is the aim of 3 markers in which they are testing us is that the aim is that whether you know your pharmac, whether you know your micro and forensic or PSM well. So these are the topics which you might not study a day before exam. For example, they might ask you adverse effect of statins, adverse effect of DMARDs. Those are some questions which you need to know. So one question related to pharmac, actually than one, I can say you two. One something related to side effect, some related to the pharmacokinetics part. Okay. Then also if here, for example, if they have asked about vitamin deficiency in 5 marker, they will ask something related to nutrition in 3 marker. For example, total parenteral nutrition or something like that. See, the nature of 3 markers depends on 5 marker as well as 10 markers, and itself is unpredictable. But make sure you study all this and go so that you know 70% of your paper, attempt it, and you can pass your exams and come back. So related to CVS, you might expect 2 questions, depends on what is 10 marker and what is 5 marker. So here in CVS, what are the 3 markers which you can expect is Jones criteria. And basically here they will test you the clinical skills which you have acquired during your posting. For example, clinical signs of chronic AR, types of cyanosis, causes of clubbing. Those are the questions which they focus in 3 markers. So 3 markers are always straight and you need to know to the point. So it's always to the point answers. Okay. Then related to GI, they might ask you about hepatobiliary, that is drugs. They might combine this with pharmac and ask drugs, hepatotoxic drugs or something related to that. Okay. And endocrine also something related to Cushing's, and also the electrolyte part, that is hypercalcemia or hypocalcemia. Okay. And also syndrome, some syndromes can be asked for 3 marker. So this is also related to CVS, so you can just merge it. So something related to stenosis or something related to that thing they have asked, and also the pharmac thing which I have explained you earlier. So the hepatobiliary part again depends what they have asked in the 10 marker. If the hepatobiliary part of that is asked, then they might ask something related to GI. So what I would like to say you is that whenever you start a paper, so for example, if you are revising, think it as a revision video. So first, always start with the major subject. That means go through the same topics which you are going through. See, for example, the aim of the overall paper, see for example, I am not discussing about MCQ. See, the aim of the paper, first is to pass, second is to get good marks, third is to get distinction. So to pass, you need to know what are the things what the examiner expects you to know. So these are the things what I feel he expects us to know. For example, while revising, make sure you study like this way. For example, you are revising CVS, so make sure you study heart failure. Make sure you study MI. For example, one time they are not asking about MI, but they had replaced with ACS, that is acute coronary syndrome. So they might change the words, they might play with other words, but make sure you know all of those. So something related to that will be asked. So while finishing endocrine, make sure you study all something related to thyroid, hypertension, cushing, and hypocalcemia, all those things. And make sure whenever you are revising, you revise it in the same order of what you will be writing tomorrow. For example, if this is the pattern, right? So obviously all will attend 3 markers first. So 3 markers is something which you need to have a grip, and 3 markers is something which you will answer on spot. If you ask me, yes, you have to study all single questions, there is no alternative to that. But after this, whatever this part is kind of predictable, there might be 2-3 questions which are out, but almost 6 to 7 to 8 questions are predictable by the nature of exam. So make sure you study all this topic. So what I have did is, so for example, now the major thing is, you know what can be asked for, what are the short questions for 5 marker. For example, rheumatology is something which is almost like short question, correct? So that's the topic which I have bought, I'm discussing in the coming class. See, for example, this is the so while reading first, you know the knowledge. So just to pass, if you study all these topics, I repeat all these topics, then sure you're gonna pass. Then to get good marks, make sure you study all the competency based thing. Then to get distinction, make sure you revise. Revision is the key to success. So based on this, I will discuss about the immunology or the rheumatology part of it. So as you know, the maximum weightage here is 6 marks. So only you can expect a 5 marker question or a 3 marker question. So whenever you are preparing for exam, I repeat, only for exam, not for acquiring knowledge, make sure you tailor your answer for 5 marker or 3 marker. So what is the questions which you'll get for 3 marker? You might get syndrome type of question, or you might get something related to criteria. But 5 markers is always management or investigation. The consistent questions which are being asked in rheumatology or rheumatoid arthritis, SLE, for 5 markers. In and out of RA is being tested. Clinical feature, manifestations, management of RA, or it might be extra-articular manifestations of RA, or it might be related to something related to, for 3 marker, also I want to add about the drugs, DMARDs, which is a favorite question for them, overlapping with pharmac. So these are the questions which you need to know. So coming to the rheumatoid arthritis part, so this is what they have asked: the pathogenesis, clinical feature, diagnostic criteria, investigation, and extra-articular feature. So whenever you are writing, start with the definition. So as you know, it's a chronic thing, and it's an autoimmune disorder which will affect the synovial joint. So this is something which you know. So also have a sound knowledge. For example, whenever you talk about rheumatology, it's a triad, or it's a subject which comprises of arthritis, connective tissue disease, and vasculitis. So I have this broader concept in mind, and even in arthritis you might have degenerative, seropositive, seronegative. So all those things have that base, that is the overall concept which you need to have, but I cannot discuss it for the want of time. So based on that, you jump to this chapter, then write the definition. Pathogenesis, I have copied it from Davidson, you can refer that part. But pathogenesis itself is not important, because the major part which they focus is on clinical feature and manifestation. But for sure you can refer this pathogenesis. Basically, it's a 5-step process where you will identify where there is a trigger, where there is autoantigen which is formed, where there is immune activation, and there is an inflammation cascade which will cause the tissue damage. Just go through it so that you know the entire part. So next, coming to the clinical feature, the major part is you need to divide it into articular and systemic. Okay, so whenever you start with articular, this is something which you know: symmetrical joint space swelling, early morning stiffness affecting the small joints, and general, make sure you present this thing. And extra articular feature, so these are the things. So for example, I have just made a small mnemonic so that this is something which is like short question. So at the time of exam, I should just write it off. I should not even think once. So that's what I made. So POVCAN. So these are the causes. So these are nothing but P stands for pulmonary, O for stands for ophthalmic, V stand for vascular, C stand for cardiac, A stand for amyloidosis, N stand for neurological complications. So about manifestation. So this is something which you know. So this you can remember. So and also all rheumatological conditions will have ILD. So this also you can, this is something which you can remember, and this is something which is very very important. So this can be even asked for MCQ, and this was also a neat PG question. So something that is subluxation of cervical spine. And also while writing cardiac, you have to remember all carditis. And also I would say you will remember this, and you will forget the most important thing which people forget is amyloidosis. Okay, just remember that part. Then investigations, while writing investigations, divide it as to establish diagnosis and to monitor the disease activity and drug efficacy. Write all these things. And also while writing that, make sure you write it for screening, so that this is an initial step, and for serology and also the radiological investigations which you would do. And coming to the criteria, this can be separately as for 5 marker or 3 marker itself. So divided into, so whenever there is a classification, remember that making the disease easy or prognosis or treatment easy, a classification is always done to ease the disease or ease the treatment. If you are finding it difficult, make sure you go back to concept, make sure you go to ChatGPT or somewhere and ask what was the need to make a classification. So here, to diagnose the condition, we made this. So while remembering, you can just remember it as 2 clinical feature and 2 investigation. So 2 clinical feature is about the joints affected and the duration, and 2 investigation is the basic investigation. So serology, that is RA, and also the acute phase reactant, because these are cheap. So once you are suspecting that, you can go with anti-CCP as well. So whenever there is a score of more than 6, then it is definite of R. Okay, so make sure you know this, revise it. So whenever there is a classification, divide and revise. This is the major thing. And also while writing the management, write goals. So need to suppress the inflammation, control symptoms, and also provide a maintaining functioning limb. So this is this management protocol I have copied from Davidson. So it can be broadly classified as pharmacological and non-pharmacological. So this is at the end stage, but this is to increase the functional mobility of that. So the basic concept, I'll just put you forward with the basic concept. So this is to reduce inflammation, and this is to reduce the disease progression. Okay, so based on this, you will call the patient to monitor the disease activity. So you can just remember it as 3 for convenience. So there is a formula to measure the disease activity, not important for UG level as far I feel. Then if it's less, then you can continue with METO, because you cannot keep a patient on long-term steroid. But if the disease activity is increased, then you can add sulfasalicin or chloroquine. Then again measure the disease activity. Just remember it as 3 to 5 for convenience. If it's less than 3, continue all 3. If it's 5, you cannot subcutaneous METO or DMARD. You can add different DMARD. But if it's more than 5, you have to consider adding biologics. So next question is about ankylosing. So make sure you revise and go. Major thing, ACR Euler criteria, then extra articular manifestation. Make sure you know that POV can. Then the protocol which you need to follow. That is like the most important thing. Then coming to ankylosing spondylitis, remember these headlines: seronegative, then etiopathogenesis is not required, then the clinical feature remains the same. Make sure while writing clinical feature, you classify it as articular, then general. Then the same thing which you had classified above, no? So it's articular or systemic. Sorry for that. Okay, systemic. Then you classify it as general and extra-articular. The only thing which is consistently changing is the lower back pain. Okay, so remaining and enthesitis, except that it remains the same. And here one more component which is being added is the HLA-B testing. Okay, the same protocol. Okay, the aim is to reduce pain, so you give NSAIDs to reduce disease progression, biologics, and to prevent complication. Reactive arthritis definition is not required. It's the same thing. I'm not talking much on that because it's not that important for your exams. You can go through the PDF which I'll be uploading. Gout is something which is important. This is a monoarthritis. Then again here we go with the same LFT, RFT and uric acid. This is the key. And the management part, so you have to write about the advice, general measures, and how do you manage acute gout and what do you give for prophylaxis. Oral colchicine is a wonderful drug to manage acute gout, and also to reduce the disease progression we can use all the biologics. Okay, systemic lupus erythematosus is something important, and I think this might come for 5 marker this year. I don't know, even RA is a good question, but this has not been asked still now, so I feel it's an important question. So there is a statement, I guess, any female who has been not been diagnosed with anything, and is at the reproductive age, and has some kind of chronic fatigue syndrome, polymyalgia, you have to work up for SLE. So SLE can present in multiple ways. Okay, so while writing SLE, make sure you know the clinical feature part of it. So divide it into general symptoms and systemic symptoms. Firstly, divide it into general and systemic. Then in systemic, add all these things. You might add arthritis component, then vasculitis component, then renal component, skin component, CVS component. Everything need to be added. So the diagnostic criteria which we use is out of 11 features, 4 features has to be present simultaneously. So these are the features. You can just go through with that. There is nothing more. It's something you have to remember. Okay. Next, again, while writing investigations in immunology to diagnose, to monitor disease activity, that you are going to do that. Then management part, just first you have to give the general advice, then classify it to mild to moderate, severe, and the maintenance dose. So mild to moderate is everywhere you have to write the management goals, if it's for 5 marker or a 10 marker. These are the drugs which you give. But for severe, you can either give me a pulse dose methylprednisolone or cyclophosphamide. So this also can be a 3-marker onco-associated disorders. First, divided into rheumatological and non-rheumatological. I'm sure this is the easiest thing which you can remember, but also this thing is something which you should know. Then there's something called as Felty syndrome. So whenever you come to syndrome, my advice would be go back to the history. Ask the HPT why was it made. So if you go to this Felty syndrome, when rheumatoid arthritis was common but the rheumatology part was not evolved, the clinicians add only basic investigations and clinical examination. So whenever a patient of RA has neutropenia and mild splenomegaly, it implies is gone into an acute phase of chronic RA. So that is the importance of that. So don't by heart saying Felty syndrome equals neutropenia, RA and splenomegaly. No, that's not the way. Go back to history. What was the missing that you need to connect the dots in medicine? So after that, I think based on this you will remember for a long time. Then DMARCs is something which will always ask for 3-mark club with pharmac. So divided into conventional, biologic and targeted. So something which I remember is this is HCQ and methotrexate, which all can remember. Then JAK inhibitors, you can just write the name. But for targeted, I always remember B20, that is rituximab CD20, because that's something which is there in all chemo regimens. So these are the indications. Then for they might ask you for causes of hyperuricemia or gout. So it's something to do with just pathogenesis, whenever there is increased intake or decreased excretion or increased production. So whenever you are saying these two are not the same, increased production is in the sense it is due to body, but increased intake is by you, that is you are intaking it. So these are something. So while decreased excretion, you can blindly write CKD, and here you can blindly write neoplasm, and these are the these are the things which you know. So, and also this is like the favorite Viva question. I don't think I need to discuss. Where do you find very high ESR? And if you don't say TB, I'm sorry, I don't know what to say. So TB should be the first thing. Then it's multiple myeloma and also the giant cell arthritis. These three things you should know in and out. So this is something which I need to say about immunology. So the basic thing which I would say is 5-mark or 3-mark. 5-mark RA bar SLE, 3-mark drugs bar Felty syndrome, or something to do with the diagnostic criteria, that is ACR Euler criteria. Only so much and you are done a day before exam. Okay. Then coming to the endocrinology part, I have broadly dividing into diabetes and thyroid. So basically first I will discuss about the thyroid part. So here it's an overlap. This might come for 5 marker or that might come for 10 marker. So these are the 10 markers which was asked. This was the 5 marker and this was the 3 marker. So based on this, we'll approach the endocrine. So the first question which we'll be talking is about the thyrotoxicosis. So these are the causes. So make sure by dividing writing causes, you divide it as thyroidal and extrathyroidal. Okay, so in thyroidal you can write all the thyroid states which you know, that is it might be Graves, multinodular, solitary, thyroiditis, where there is release of thyroid hormone. Make sure you know that and you write the thing. And clinical features, yeah, you can classify it as the last part where we is general and systemic, but this is what something is followed in Davidson. So I'm just followed that part, that's it. It's not my own thing. Whatever is I have followed this, whatever I have followed, whatever is given in Davidson, I've just written it. So you can divide it into most common cause, less common cause, and rare cause. Based on this, even in the examination part is there. So obviously sympathetic overactivity thing is there in most common cause, and these are something to do with chronic thing, and these are not specific kind of thing. So on examination, this is something which you should just know. This is just a box given in Davidson. And also investigation, make sure you do the preliminary. It's a clinical diagnosis, let me be very straight. You just need investigation to prove your diagnosis. So TSH and FT4 is something which you do, and to look for complication you just see for sinus tachy and AFib. So management, you need to treat the underlying cause. So the aim is control AFib if present, and if there is AFib and if you are not controlling it, you might have a thrombosis. So that's one thing which is important, and hydration is the key. Propranolol is the drug of choice for thyrotoxicosis, as you know. Then glucocorticoids to reduce inflammation, and PT or metimazole to reduce the production. Okay, then hypothyroidism divided into primary and secondary. Primary itself in classification mean disease something related to the gland. Second is extraglandular. Okay, so based on that, go with the statistics. Most common is nutritional, that is iodine deficiency. Then autoimmune cause Hashimoto thyroiditis. Then iatrogenic radioactive iodine apparition or thyroidectomy or drugs. And transient is due to infection, for example thyroiditis, all those things. Then congenital condition and infiltrative condition. Many people forget this part. Okay, I'm just making a note so that you don't forget that. Then clinical features, same thing. I've just copied it from Davidson and I've just shown it to you, but this is something which I've done it ulta, so make sure you know that. Then investigation part, aim. You should know your aims for your investigation and also the management. So preliminary, to differentiate between primary and secondary, so you need to have TSH. Then supportive changes, for example in ECG you might have sinus brady or low voltage thing, all those things. Then if it's persistent, then you need to find out whether it's due to something else. So these are the investigations which you would do. Okay, and to look for autoimmune etiology, you also do anti-TPO. So management aims. So here again you have to replace the thyroid drugs, and importance of follow-up, because the dosage changes. If there is active infection, you need to double or triple the dose. There's something like that. So you need to stabilize the dosage. So there you have to consult about the importance of follow-up, and also you need to address other concerns like dry skin, dry hair, where you give moisturizer, and also you need to address that it might take 3 to 6 months to have that kind of hair and skin. Okay, but the redness and puffiness might reduce quickly. Okay, this is the diagnostic algorithm which is there in Davidson. So first you have to identify whether it's primary or secondary. So before that you have to check whether there is thyroidal, non-thyroidal illness. So in that also there might be slight elevation. So first you have to do that. So before that you give you have to go with TSH and T4. Then again divided into primary and secondary. This is based on statistics on what is it common. Obviously infections are something which is always common, so first rule out infection. Second is iatrogenic. Third is all the thyroid related things, and again autoimmune cause. So that's why knowing the statistics of a disease, if you go through our lesson, the first thing which they talk about the incidence. Why do you think so? Because that based on that your investigations are managed or is written down. So that's why you should know that part. So if it's something due to that, then you can give temporary T4 replacement. Then if the drug is relevant, then you need to continue with the same drug. Then after, for that condition, for those time you have to give T4 replacement. Then for all these things you can give permanent T4 supplement. So Graves disease, this is what is given in Davidson. So first thing what happens, it's the hyperthyroid state, then it's a euthyroid state, then it's a hypothyroid state. So again, management again can be classified as the acute condition, that is thyrotoxicosis crisis, and also you need to address the ophthalmopathy which is present. So for that you need to reduce the gritty sensation in the eyes. So for that you give methyl and also to reduce the ocular involvement. I repeat, to reduce the ocular involvement, not after the ocular involvement has been set in. So there you give selenium, and also if it's a severe inflammation, obviously go with steroid. And if there is a loss of visual activity, it's an indication to go for surgical decompression. And this is something which we have discussed. I'm not going to the part of it. And this is to do with mixed edema coma. So I will explain you the concept. I know this is not clear, but while uploading the PDF, I'll make sure the part is clear. So here, whenever there's a old age people, so them going into hypothyroid and having this kind of condition is very common. Again, it's a triad of CVS, CNS, and hypothermia. Then again, you have a lot of other features. Then again, it's a clinical diagnosis. Again, you do investigation to support the diagnosis and to look for complication. Again, you have to go with it's an emergency, so you have to write ABC. Then you have to give supplement. Then you need to treat infection. Always you have to treat the electrolyte as well. So this is the broader outline for thyroid disease, which is an expected 5 marker or a 10 marker for your medicine paper 1. So now I have to I'll go with other part. There are other questions as well, but for 3 markers let me finish it. So causes of gynecomastia divided into physiological and pathological. Right, physiological at the time of puberty due to hormone imbalance. Then other parts, that it might be drug induced, the famous disco drugs which you all know. Then estrogen excess, liver failure, which you have all seen involved. Then Klinefelter syndrome. Then also androgen resistance. So then causes of hirsutism. So for hirsutism to happen, you need to have androgens. So wherever there is androgen, you can just write it blindly. Here also serum testosterone is raised. Here also it's a congenital adrenal hyperplasia. So again, even in Cushing's, as well as exogenous and also androgen secreting tumors. PCOS, please don't forget, most important. Then Turner syndrome, obviously, why to clinical features, I am sure you know that diagram. I have not put up here, but I am sure you remember that. So writing about the investigation, obviously to know the diagnosis you go for karyotyping. To look for associated symptoms, you go with all these things. There are many things, but I've written less because it's a 5 marker or a 3 mark question. Then for management, you need to address all the concerns which the patient have. You need to also have a genetic counseling, all those things. Then estrogen therapy, and also prophylactic gonadectomy, and also you need to address the growth. Okay, 1 second. Okay. Now coming to Cushing's, I'll come to that part. So Cushing is something, there is a beautiful statement in medicine which they say, one who knows about Cushing has not seen Cushing. What a great statement is that. So with that, let us go into Cushing. So the major thing which they take is common is exogenous part, then endo. Then obviously it can be either primary or secondary or pseudo. So medicine is simple, man. You have a template, you need to fit it into place and go. There is nothing extra you need to know, provided you know your physiopatho and that things well. So if it's ACTH dependent, that means it's being secreted somewhere else. It might be either from pituitary or ectopic in case of carcinomas. Non-ACTH, something to do with adrenal gland itself, so something to do with adenoma or carcinoma. Then pseudo is due to somewhere the steroid is being taken, so it is either due to obesity or alcohol excess. Okay. Then clinical feature also, there is a diagram. I think you all know from first year, so I'm not discussing. And investigation aim. So first thing is to establish whether patient has Cushing. To diagnose or to label the patient as Cushing is not easy as you think. So these are the 3 criteria which you need to satisfy. Whether you have to check whether you are able to suppress serum cortisol after a dose of oral dexa, or whether there is a normal circadian rhythm and there is excretion. So whether the physiology is balanced for this, and whether there is a physiology which is maintained, and whether there is a physiology for excretion. Okay. After that, the second aim is to identify the cause. Okay, so for that you go for ACTH level. Then these are the other investigations which you will do to support your diagnosis. And these are the tests Wow, this is the thing where they explain you how to go with test. Not important for your exam, just for knowledge I've written. So obviously it's a surgical thing. So what you do is there's a high mortality rate, so I've written the prognosis part. So surgical is the mainstay, primary, secondary. If it's a secondary cause, obviously you go with transperineal surgery. But before that, you need to stabilize the patient. So for that, you can give the drugs. Okay, then how do you manage the adrenal crisis? So this is a potential 5 mark or a 3 mark question. So I want to say you that. Okay. Then adrenal additions. So addition, see what happens is first you will have glucocorticoid or mineralocorticoid. Later it will present with both. So glucocorticoid means glucose. This is something to do with potassium. Have this in mind. Okay. How do you manage it? So first thing is you have to correct the volume depletion. That is IV saline, because it's a state of volume depletion. Then, as I told, you need to reduce the inflammation because you don't know where is it happening. So wherever you are giving an emergency steroid, no, it's always hydrocortisone, because by the nature it's a short acting drug. It is a fast acting drug. Okay, then you can start on parent drug. Then correct other metabolic abnormalities as potassium or acute hypoglycemia, and you need to treat infection or any other cause which is being maintained. So you know the pathophysiology, you know the physiology, so you just need to block it. There's nothing. Okay, then you have acute and chronic. So what is there is a statement given in Davidson where they say many of the chronic conditions are misdiagnosed as chronic fatigue syndrome, or they're having depression. So need to revisit or relook whenever there is a clinical case presentation like this. So again, you need to take the GRPS sample. Then most common causes are obviously abdominal TB. You need to check for that and you need to treat that. So the next part is either for 5 marker or 3 marker, you will get hypercalcemia. So obviously, whenever there is hypercalcemia, see the history part of this is very important. So what they taught was in the early period, they thought calcium is something to do with bones. But after the thyroid surgery, they saw that few of the parathyroid or few of the patients were collapsing due to hypercal. So they didn't understand what is happening. Then when they did the autopsy, then they came to know, they discovered parathyroid gland. Then they discovered they might have some relation. So that's how parathyroid relation with calcium was identified. There's something called as tertiary. So what happens is tertiary is that primary equals a tertiary, but but here the compensation mechanism of parathyroid has failed. So where do you see the tertiary is in either CKD patient or CLD patient. Okay, then there is something called as familial hypercalcemia, where there is a loss of calcium uh, in the urine. Okay, but which is the most common cause, which you cannot forget? Malignancy. Okay, so this is common, this is common, this is common, this is common. So you need to know what are the things which are common. So based on that you can write. So clinical feature 50% are asymptomatic. Then you know the famous dialogue, stones, bones, abdominal Crohn's and psychiatric bones. You can write on that. So though many of the people don't present like that, then you might have non-specific symptoms. Then if you have a family history, then think of men and FHH. So and also I want to talk about men. So whenever you find a parathyroid adenoma, no, it's always crucial to screen for men 1. So go back to history of men, read about it. It's very nice. Okay, why men to A and men to B was why men to B was why men 3 was later classified as men to A, all as concepts. History, whenever you are stuck, make sure you go to history, because a person who doesn't learn history will never create history. A person who learns from his mistake is a good person, but a person who learns from others' mistake is a wise person. Okay, so just motivational thing. So next thing is so the investigation, obviously to diagnose you need serum calcium. To know whether it's primary or secondary, you go with serum parathyroid. To know whether CKD CLD is there, you go with this urinary calcium for FFH and CT MRI to know the malignancy part of it. So management, obviously you give calcium chelation, and this is something which is given for malignancy related hypercalcemia. You go with this, where you give IV 0.9% saline, that is 2 to 4 liter. Then you go with zoledronic acid. Then if it's refractory, you go with denosumab. Hypocal, same thing, you have to correct albumin, check its correlation with magnesium and vitamin D deficiency as well. So this is something which you are learning from physiology. I'm not going to do that. Maintenance part, I think this is something which you know, and also correct magnesium. Okay. So that's it with respect to endocrine, excluding diabetes. Okay, this is excluding diabetes. So major things which you need to focus here is thyroid. Second is questions bar additions. Third is something related to electrolytes. Okay. So based on this, I would like to go with diabetes mellitus, which is almost a for sure 5 marker or a 10 marker, mostly 5 marker for your exam. This is something to do with OBG. I'll be discussing in that. Something to do with pharmac. Okay. So this is something to do with Modi. So usually for 3 markers they might ask it. There's nothing to learn. You just need to go through this. Okay. Then DKA. Alternating year they have asked either DKA or HHS. In and out it should be. I'm not even exaggerating. Alternate year they have asked for 5 markers because there are no any potential. There are potential questions, but I don't know. Okay. So the question is causes of coma. Remember it as CME, that is cerebral, metabolic, and electrolyte. Obviously, the case which they give is DKA. So and also HHS. So just go with that. Then clinical feature, it's a triad of hyperglycemia, hyperketonemia, and metabolic acidosis, which you all know. Then clinical features also you can just write it broadly. Then on examination, dehydration is something which is and also the ketone bodies we will mention. Investigation, obviously, to diagnose and to look for complication. Whenever you are saying to look for complication, what are the two things which will come to your mind in medicine? ABG, electrolytes. And also you can go with bun and all those things. And Davidson has also mentioned to go with pregnancy test. I don't know why, but it's given. I've just written it. Okay. And also you ECG is something, CXR is something which you should know. And acute MI can precipitate decay. There is a statement. So you have to screen for MI and also you have to look for consolidation to check for infection. Then this is something which is there, but I will just replace with this. Go check pH. You know the normal value is 7.35 to 45. If it's more than this, it's severe, then moderate, mild. Then aims, you should know the aims. If you say DK is managed by insulin, please, I'm sorry, it's not. You have to say volume. It's a state of dehydration, both DK and HHS. First answer which you should say is IV fluids. Okay, so first you have to correct that and also balance the electrolyte, and also you have to treat and cure the precipitating factor which we have discussed, that is MI as well as the infection part of it, and you have to reduce the complication. So this is something which is given in Davidson. I don't know, this is a bad diagram, so I have just put up this diagram which is given in Davidson. So what it says is, see, draw the same thing. Okay, so what it says is first fluid, as I told. So you need to check for BP. So if the BP is high, then you have to give 1 liter of NS over 60 minutes. But if the BP is low, then you have to give 500 ml in 10 to 15 minutes. Then again you have to take, if it's still low, then you need to call your senior. Then again 1 liter for 2 hours, then 1 liter for 4 hours. So aim again you write to maintain urine output for more than 0.5 years. So then again potassium normal value is 3.5 to 5. So based on this you will add 40 millimolar of KCl. Then here insulin, this is a fixed dose of insulin which you give 0.1 unit per kg. Then you assess ketones, not sugars. Okay, because that's what, whenever you are going with the management part or investigation part, ask ChatGPT where did they go wrong or what did they made wrong. The major mistake what they were doing was they were checking glucose, but when they made correction, when they stopped giving insulin after glucose, ketonemia reversed back. Okay, so that's why ketone is assessed. So if it's more, again you have to continue insulin. This is the aim. And if it's more than 0.5, then you have to check whether you are pumping the insulin well. So draw the same diagram. I've explained you which concept. This is something to do with dehydration. Then you need to give insulin. Then you need to start with potassium. Okay, if you know this, I think you can manage. The same thing I've written, nothing else. Then the next 5 marker which they ask is non-ketotic hyperosmolar coma. This is due to prolonged relative insulin deficiency. Okay, so again the clinical feature is same. Again the aims here is same, except osmolarity and cerebral edema. And also here, let me explain you. Though you give fluids and insulin here, so the thing is you will almost have 6 to 12 you must almost, I think, if I'm not wrong, I think you have 12 liters of relative dehydration. So obviously you will start with fluid first. So it's the same thing which you had followed there. Then after 1 hour, you make sure the rate of fluid is 1 liter and you assess the osmolarity. So this is also something which they absorbed. So whenever they were correcting the osmolarity more than 8, cerebral edema was falling. Whenever the rate of fall of sodium was more than 10, the myelinosis syndrome, pontine myelinosis was happening. So they reduced it. And also, why did they reduce glucose? Why did they start giving glucose? Because glucose is also an osmolar substance, so need to maintain in the fluid. So that's it. And also they maintain the KCl supplement. Okay. So you know why this is happening. Then again you have to start with insulin. So here you start with less insulin, and also you assess the same thing with ketone. Then again after, why 1 hour and 6 hours? 1 hour is to check how you are doing, how is your management, and by this your kidney would have been returned to normal. Then to start with subcutaneous thing or parenteral thing, we go with 6 hours. So you just need to know that so that you know what you are doing. Then hypoglycemia, these are the questions which they can ask for 3 markers. So I've just written it down. So you know less than 54 is dangerous. So based on that, less than 54 is severe. Then clinical feature, again just copied from Davidson: autonomic, neuroglycopenic, and non-specific. Causes, obviously it's a 3 marker. So just remember 3 things. Or if you can remember all, it's good. So these are those things. Then management, make sure you write about the counseling part, because hypoglycemia is more dangerous than hyperglycemia. So make sure you know that. Okay. Then complication. Yeah, complication. This is something which you are studying from all pathies is micro. Then macro is CAD and peripheral. Here again you can remember, for if you want to get full, then you can remember, sir, that is skin complication, infection, and rheumatological complication. Then they have asked about the classification of neuropathy. So Glovenstock is something which is common. So this you can remember. And autonomic, like hypotension, is also common. So you can also have entrapment like carpal tunnel syndrome, and mononeuropathies like cranial nerve palsies, then some trunk pain, thigh pain, all those things, and truncal loss. So treatment, have to just write TCS, anticonvulsant, low dose, and opiate analgesics to reduce the burning gritty pain. Then metabolic syndrome, you can just draw an umbrella and you can remember. So there basically it's 5 things. So I remember it as 2 clinical features and 3 investigation, that is dyslipidemia, then insulin resistance, then pro-inflammatory markers, then BP, high BP, and increased obesity. So this is about diabetes. Major thing which I would ask you to remember is DKA bar HHS or 3 marker. Also you can expect few questions something related to, for example, for 3 marker you can remember OHA drugs, side effects, which is better, and also something related to insulin part. Okay, that's it for the endocrine part of it. Now we go to the gastrointestinal system, including hepatology. So this is the marks distribution. This is rough, okay, might not get the same. So in gastro, even pancreatitis was been asked, but I've not seen in recent papers. You can study that for 10 marks. These are for 5 and these are for 3. So the causes, obviously you know, it's gallstone, alcohol, all those things. It's I need not say explain everything. The notes itself is self-explanatory. Wherever there is a requirement of explanation or wherever I can make it easy, I'm just explaining that part. Then obviously this is abdominal pain, and also you know all this greater sign, then Cullen sign, which you have been sure you'll be discussing in your clinical lectures. Then again investigation to diagnose, to look for complication, to exclude other cause. So you to the major complication here is effusion. so you need to check for that. Then management part, these are the aims which are required you need to achieve. So you need to establish the diagnosis, and may check for disease severity. Make sure you club this with surgery part, okay? Then you study so that you have a proper clarity. Then you have to do early resuscitation because there might be fluid loss, and if there is paralytic areas, then you have to go with NG aspiration as well. Then you need to treat thromboembolism, and also to prevent infection, you can also give antibiotic prophylaxis. Then you have to treat the underlying cause, that as if there is cholangitis or pseudocyst, you need to drain that. Okay. IBS. Okay. IBS is not equal to IBD. Let me be very clear. So this is something to do with functional or psychiatric thing, which I feel it's actually is not I feel. So the clinical feature. So the diagnostic criteria is you should have recurrent upper abdominal pain with two or more symptoms related to defecation or change in frequency of the stool or appearance of stool. Okay. So the criteria which you use Rome for criteria, this is something see, gastrohepatology is something to do with surgery. I will upload that video as well, but for medicine you make sure you know this. Okay. Then rule out other cause because it's a functional disease, so you should make sure you have ruled out all pathological part of it, and obviously you go with CRP and fetal calprotectin to rule out IBD as well. Then major thing is counseling, and there's something you have to, there's something called as food map diet which you can go and read upon it. Then you need to address the main symptoms. Then there's something to do with the clinical features of fetus, you can just go through with that. Then the pathogens of H pylori, I'm sure you know this, I'm not talking much because it's something to do with micro. Okay. And patho also. The investigation, make sure you write it as invasive, non-invasive, which was given in Apurva Shastri in micro. The same is given in Davidson as well. So you go with this, and also you go with endo to rule out any other metaplasia or carcinoma thing. Okay. Then aim is to reduce symptoms, to promote healing, and to prevent recurrence. Okay. If you know aim, you can write treatment as it is. Then GOD also, there's nothing much I need to discuss, but while you just write treatment as PPI, no, you write the aims. Then this is something is very important. Seattle protocol, I'm sure you have studied in surgery, so you need to do regular endoscopic evaluation for that part as well. So also you need to treat the anemia. If there is stricture, you need to treat that. Then if there is gastricolulus, you have to treat that. Then if there is any paralytic areas, you have to surgically decompress it as well. Oh, okay. Even the ulcerative colitis part, it's a sure 5 marker or a 3 marker, but there is some problem with the page. While uploading, I will make sure it's the correct one. So again, intestinal, extraintestinal, same thing. Then assess the disease severity, mild, moderate, severe, based on bowel pattern and blood in stools and stool volume. This is what I remember, the stool volume thing. Then differential, infective, non-infective, obviously all the diarrhea part, and non-infective, as you know. Then complication, make sure you write it well. Malignancy, divide it and then write. Then investigation, same aim, confirm, define disease distribution and activity, and identify the complication. Then treatment. The major aim, you have to talk about the major aim. So if it's an active disease, then you have to start with check whether it has proctitis or it's a left-sided extended ulcerative colitis. If it's that, then you just start with aminosalicylic acid. Even here you start with the aminosalicylic acid, but you also give a glucocorticoid suppression dose there. But for acute attacks, you have to give this. Then to prevent, obviously you need to give disease modifying agents. Then if there is any, you have to detect dysplasia and carcinoma as well as a part of your management. And again, if there is any increased risk of strictures, you need to do stricturotomy. So it's a combination of surgery topic here. I cannot explain everything here, but in surgery part, I will explain this part well. Okay. So hepatomesis, that means you're coughing off or you're vomiting blood out of your vomit. So you have to write about the causes. Then you have to divide all the organs which is being present with the systemic. Whenever you're writing something to do with blood loss or related nearby organ plus systemic cause, which you have to mention. So this is self-explanatory. Then they have asked about indication, contraindication, and complication of upper GI. So again, whenever you are writing, you can write for therapeutic procedure and diagnostic procedure as well. So these are the things. Contraindication, you have to write absolute and relative. Okay. Complication, again, common and serious. Okay. GI is, that's it. So major important thing which you should know in and out is ulcerative colitis, then IBS, not as recently, but hematemesis, upper GI bleed is something which you should know. Okay. Next, we'll go to hepatobiliary. So it's a 10 marker which has been also asked, and here the if it's a 5 marker, as I told, there is a varied options where you can ask SPP, hepatic NCAF, and also cirrhosis. Sorry, cirrhosis is also an important 5 marker bar 10 marker, or hepatitis. Okay. So here again, clinical features is something we'll talk with about SPP. Okay. uh, Again, this is something which I have learned from 3 years involved. So whenever the bacteria migrates from intestine to ascitic fluid, you give this hepatitis. So a diagnostic is something, this is a 3 marker. Okay. So remember, this more than 250 into 10 to power 6 per liter, or gross cloudy fluid with culture, you can diagnose SPP. So you have to talk about, and also a diagnosis to rule out other condition. Then prophylaxis as well as the treatment part you need to focus on. Hepatic NCAF, again, what are the precipitating factors, then what are the investigation again to diagnose, and in ECG you get diffuse flowing of diffuse flowing of normal waves. Then also the aims part, again remove the precipitating factors. Then you need to reduce the ammonia content, so you give lactulose and Lola. Then antibiotic prophylaxis to prevent SPP. Then also if it's a refractory case, then you can plan for liver transplant. Then cirrhosis of liver in and out, it's a potential 10 marker or 5 marker. So again, divide the cause. Here you can remember it as again in, okay, IB, okay, okay, something whichever you feel is important. This should come as it is on the day of exam. So A for alcohol, I for infective, M for metabolic, then immune and biliary thing. And also you have genetic name, something, make a mnemonic and just remember, because it's something which is very important. Okay. So clinical feature, again, asymptomatic to not very specific to complication. Okay. Then on examination, this is something you know, systemic examination also, because I'm not investing much time on this because we have studied every day in watch. Okay. So then related to management, again, treat the underlying cause. Then you need to address about nutrition, you need to address about complication which is being developed, all those things you need to talk. Then also about childhood score as well as merit score, you need to talk in and out of it. This is the potential 5 marker or 3 marker itself. Okay, you can refer other books. I have not written it much well in for this part because I thought I will do better in surgery, so I have not written much. So this is something which you should, though this is a medicine topic. Okay. Chronic hepatitis B is something which they have asked for repeatedly for 5 markers, so make sure you study this part. Uh, Again, if it's more for 6 months, then you call it as a chronic hepatitis phase. Uh, then these are the aims which you need to follow to achieve long-term viral clearance and to suppress the viral replication. So these are the drugs which they give. So again, you need to prevent it's going into HCC, going into decompensation, then planning for a transplantation. Okay. And also these should offer this treatment for HIV in endemic areas. Hepatitis C, as you know, it's a success story. You have drugs for it. The same thing. Okay, I'm not talking much, so you can just go through that. HCC, it's a surgically overlappable topic. You can go to that part, no harm, but just make sure you know this. Okay. Then these are the things which are available, but there is a protocol which is given in Davidson as well. But genuinely speaking, I have not understood it, so I have not mentioned. You can go back and refer all this. So that's it about hepatobiliary. So coming to hepatobiliary, major thing is you should know about cirrhosis of liver and also about the portal hypertension. I think I have forgotten that part. I think I have not uploaded it. 1 second. Yeah. This is so in Davidson it's given in page number 1883. Okay, I will upload that part, or it's a surgical topic, so I have not written it. Okay, so you can refer that part. So that is important, and cirrhosis of liver is something which is important. These are potential 5 marker question. So basically cirrhosis, if is as per 10 marker, or 5 marker is all these questions, and also 3 markers is something to do with pharmacoverlap. That's it. Then coming to the most important chapter of all, that is CVS, which I'm sure this all of you know by now, because this is something which is taught in and out. Heart failure, MI, these two are potential 10 marker. This is something you should know from peds. I'm not discussing here. I'm sure I will discuss this in pediatrics, so I'm not touching this part here. Okay, these are the some questions which they will ask for 5 markers, AFib or secondary hypertension or something to do with Marfan's. Here, no, aim of 3 markers in CVS is to test whether you know clinical signs of disease. Okay, that's it. So based on this, you go through these things, so you will understand. So classification, this is the latest classification which you have based on ejection fracture, whether it's preserved or normal or reduced, or whether it's an acute decompensated heart failure. So this is the pathogenesis which is given in Davidson. I've just written it down. Then etiology, it might be, so just explaining things here. So something, whether if preload is affected or myocardial contractility is affected, or after load is increased. So based on that, you can write the pathogenesis as well as the etiology part. Then clinical features, you can just draw the diagram because it was given in Davidson. I just written that. Then the complication part, obviously you need to write everything. So this is what is given. This is something which I'm sure you will write, but also you need to write about the electrolyte. Whenever you are talking about complication, electrolyte is first, then embolism is next, then also about metabolic complication like metabolic acidosis, all those things, then also because of venous congestion and arrhythmias. So whenever you are writing complication, make sure at the end you will write that. Okay, next coming to the investigation part. So X-ray, echo, and to detect the nature of the affected system. For example, for ear, it's a preliminary investigation. Okay. Then echo to determine the etiology. Well, whenever you are writing a investigation, you should know what is the aim, why are you doing it, or what are you finding it, what are you getting it after doing it. Okay. Then also to differentiate between other cause, you can go with probia. Then for management of acute heart failure, obviously it's a medical emergency condition. You need to monitor the vitals, you have to give oxygen, then nitrates and loop diuretic. For chronic heart failure, these are the aims which you need to follow. What are the general measures? And 4 pillars. Okay, this is something which I have drawn. You can copy the same thing. So drug treatment is again fantastic 4 drugs which you all know: AC inhibitors, ARNI, beta blockers, and fibrillation. Then implantable. So these are the things. Then if you have achieved maximum dose of beta blocker, then you can go with ivabradine. Then if it's still refractory, then you can think of check the QRS. If it's a normal thing, then you can go with LV assisted device. If it's white, go for a cardiac transplant. In acute MI, bar ACS. What is ACS? A combination of STEMI, non-STEMI, and unstable angina. Okay. So I'm sorry. Okay. So this is the criteria which is there. It's also important. Okay. So I just written it down. You can just go through that part. Okay. So this is the criteria which is there. Just look into it. So you need to have a clinical science, investigation science, diagnostic sign, that is while doing angio autopsy or anything, okay, or investigation. So you need to have clinical, pathological, investigational, or diagnostic procedural confirmation. Clinical feature, I think even first standard knows. I'm not talking about it. And also these are the examination part which is given in Davidson. I just copied it. And also the complication part, something related to that part as well. But remember about Dressler's syndrome. So post-MI, if you develop effusion, it's something called as Dressler's syndrome. So you need not read that. You need to give steroids to suppress it. So you can go through with this part. Investigation, same thing. I'm not talking much because from biochemistry you are learning. I think even before you join MBBS, I think you might know this. And again the same thing. There's nothing to talk about management, but there's a protocol which is given nicely in Davidson, page number 437. If you want, you can refer. Okay. Then AFib, favorite 5 marker, a better 3 marker for its score, Chatterback's score. So this is the etiology. You can classify it as however way you want. Clinical feature DP, that is angina, syncope, dyspnea and palpitation. That's the cardinal feature of CVS. Then classification, I think you know, paroxysmal, persistent and permanent. Again, investigation to diagnose, to look for complication, then to rule out toxicosis, ECG. So this is something which you should know. Irregular RR interval with absent P wave is AFib unless proven otherwise. Okay. So you can write that. Then management obviously depends on stage and the stability. If it's unstable, obviously go for cardiovascular. If it's stable, look for echo, look for atrial enlargement. Decide whether you have to go with rate control or rhythm control. Obviously, if it's a rhythm control, then you use the drugs. Then also major thing is you have to go with Chatterback score, where you will decide whether you need to give thrombolyze the whether you need to continue the patient on prophylaxis of anticoagulation. Okay, so that's something important. If it's more than 2, then you obviously have to go with this. Then secondary hypertension, there is no paper. There is no paper where they have not asked something about secondary hypertension. Obviously, not to know about the cause, renal, endocrine. Basically, again you can divide it as genetic and acquired. This also you can do. Then drugs, then CVS, then RS. Investigation to know whether it's renal, to know whether it's endo, and to look for extent and complication. This is all the end organ damage which happens in this thing. So you need to know about that thing as well. So basically, if you need, see at the end, what is the aim is you should know what is the examiner asking or expecting you to know from the expecting you to know from you. So a day before exam is a day where you cannot study anything, but you need to know what you should not study. Okay, so the next important thing is about the Marfan syndrome. It's a 5 marker or 3 marker. So again, you just need to go about it, but here you have to diagnose the condition. You need to go with genetic testing, and to look for any other things, you have to go with all these things. Then these are the 3 marker things which are important. That is something to do with clinical science. You can just go through with that, so you know things. So you know things. These might come or might not come. Okay, so I'm not saying these are the fixed question for 3 marks, but I can promise you that out of 10, either 5 or 6 or 6 to 7 will come. So 3 marker, you can just go through it, refer all your RS questions. Then if you have time, study all. Okay, so this is something continuous murmur they can ask. Then about MS they might ask. Then about AR they might ask. MS and AR is their favorite topic. Okay, so about cyanosis also. This, if you have gone to clinics, no, you can learn. You can write on the day of exam, so there's nothing you need to study. Then about TOF they have asked. Okay, then something to do with pericardial effusion also they have asked. Causes, any cause, no, you have to go with the Robbins first page. Infective, inflammatory, neoplastic, or here they have classified it as others. That's it. Then these are the clinical feature. Then chest X-ray. So this is something to do with cardiac. So cardiac, what I would say is, make sure you know in and out of heart failure, AFib, secondary hypertension, ACS or MI. Then all clinical science ka sound knowledge you have before going to a day before exam. These are RS, but not 22 questions of a paper is predictable. But if you are able to predict even 16 to 18 questions, then you are already ahead of rest of the people in your game. So that's something which is important. Okay, so after that we'll go to the nutrition part of it. I have not written that part really actually well, but it's a short 5 marker plus a 3 marker question which is asked. Okay, so this is the thing which is there, but it's a short 5 marker or a 3 marker. So this is TPN. See what they are doing, they have alternated it. Okay, so sometimes they have asked obesity as 5 marker and nutrition as 3 marker. Sometimes they have asked beriberi as 3 marker and obesity as 3 marker. So you need to know in and out. So you need to for this lesson you should know how to answer nutrition and obesity for 5 marker as well as 3 marker very well. So this is the clinical features of beriberi. Again, again for biochem, there's nothing something to do with dry beriberi, wet beriberi, and infantile beriberi. Again, this is the triad which you know. So here, what this everyone will remember, but a day before exam, you need to know about this. Definitely, I am sure many of us would not know. So a day, you should know what you should read a day before exam. This is something which you should know. Then also about the niacin part, I think I've written it. Yeah, 3 days of niacin. That's something like donkey also knows about it. Then the Belagra, the how much dose you have to give, that is 300 mg. Okay. So if you make n, if you see it as ulta, it looks 3, no? So something like that. So you give 100 mg, you fry once in a day. Here you give thymine, see thigh. So it looks like 1, so 100 mg. Okay. So that is something which you should know. In obesity, for sure you will get 5 marker or 3 marker, but I don't know what is the question. But something related to this, go to competency, visit, think of what are the predictable questions they can ask, know what are the RS questions which they have asked, so that you know what you can plan for future. Okay. So again, see what Harrison has saying is excess adipose tissue is obesity. But you cannot write that. So Harrison is a good book. You need to expand your definition. Okay. So I written the same thing. So obviously it's quantification, I think you know. So complication, we divided it as system. Okay. So here I have not done that. Okay, systemic, I have done systemic wise, but also you can write general complication also. But this is something which they have asked for 3 mark. This is something which you should know, man. I cannot discuss this now because this is something even non-medicos will know. So divide it. So if you are feeling it tough, divide it into 18 to 40. Put a bar at 25. Put a bar at 30. Put a bar at 35. This is something which they are expecting to know. This is common sense. Okay. Divide it into half and half and half. Okay. 30 to 35, 35 to 39, more than 40. Okay. Next important thing is, see, many people what they do is they study in and out of all system, but they forget nutrition, they forget obesity, they forget pharmac things, they forget patho things, they forget micro things. So that will be a setback to you in the preparation. A day before exam is something where you have to plan. It's not like you can study everything. You cannot study every pathogenesis. You should know if these topics are limited for your 3 marker. For example, if a lesson is limited to 3 marker, it's just stupidity if you study pathogenesis. Let me be very honest. Okay, if it's a question, if it's limited to 5 marker, and it's something which is being asked, pathogenesis of that question. For example, in pediatrics, they usually ask about pathogens of TB or something. Then it's wise. But if you're studying a disease for 3 marker with pathogenesis, I don't know what to say. Okay, so I just wanted to convey this is also something which is like a short question. So as I had mentioned, they might either ask you a pharmac related thing or a forensic related thing. So these are the 2 questions which they have asked in the recent years. Not sure this question might be asked, and let me be clear, I have used this source because I saw Davidson, he has not given anything. I have seen Arison, nothing. I saw Archid Bodher, nothing. So there was no any other source. So I just used ChatGPT because I want to be honest with you. Okay? Whatever I have used, I have just shown. Because you can just go, if you have Davidson, you can just go cross check with your Davidson. This is what I have used, and that's what I am saying. For this, I have used ChatGPT, and I have no shame in saying I have used ChatGPT because I didn't find a source. Okay, so that's what a good person also has to know what kind of questions are being predicted. So for that, go through the competency thing which is being there and refer what are the questions which they might ask. So these are the 2 questions. There's nothing to discuss in it. I have just written it down. So 2 question is assisted dying and medical legal negligence. So in that, obviously you might have done AdCom sessions, seminars, nonsense and whatnot. So these are the things, subheadings which you need to talk about, and you need to talk regarding that. Okay. Then medical legal negligence, again they have asked discuss with respect to socio-cultural, professional and ethical issues. Whatever you can write. These are the 4 AdCom mantra which beneficence, non-malfeasance, autonomy and justice. So these are the professional things which they talk about. Fear of litigation or workload or burnout. Those are the things. Then socio-cultural, patient expecting you to save even a patient who is already brought that. So those are things which they expect you to know. And medical legal implication of medical legal negligence, either they can sue you civically, or I don't know whether it's a correct word, they can sue you civilly or something. They might ask you to give compensation if it's a mild negligence. They might give you a gross. If it's a gross negligence, you are under criminal line. And or MCI has the highest authority to take a command, or what do you say, decision about that. Uh, then something to do with mineral and electrolyte balance. Usually 3 marker, but this management is 5 marker. I'll say why I have not written answer for hyperkalemia. Say me a lesson or say me a subject where hyperkalemia management is not asked. Pediatrics, first 3 marker is usually that. OBG, yes. Surgery, yes. Medicine, yes. Ortho, yes. And if you don't know how to manage hyperkalemia, I was like, there is no need to write. So for sake of this thing, I'm not talking about causes for sure. So for only management aims, I'll write. So first thing is you need to stabilize the cardiac membrane, and if you don't write this, you might lose marks, but in real life you will lose the patient. Okay, let me be honest with that. So you have to give calcium gluconate. That also I note, you note an mg over 10 minutes, or 10 ml, sorry. Then you need to reduce the potassium levels. So first you will try with insulin, then you will try with salbutamol, then if it's refractory, go for dialysis. Okay, so this is something you know it already. Then metabolic acidosis, again you can divide it into normal nagma, hagma. Then you can again write it as DKA, lactic acidosis. Then all this, even diarrhea causes metabolic acidosis. All these things you can write. Just say 3 markers you should be capable of writing on spot, because the 3 marker aim is to test your paraclinical, forensic and your clinical knowledge, not on the day of exam. For 10 marker and 5 marker, you need to study a day before exam, or you need to make a note so that you study that particular thing and you go. Got it? So one more important thing which we had forgotten is poisoning and envenomation. So here 5 marker, one question usually they have asked is OP or paracetamol poisoning. These are 3 marker which they have asked. Okay, so this is one instruction which I would like to give. Whenever you are studying toxicology, study from local books. Don't go with Davidson or Harrison, because they write whatever poisoning is common there in their land. So better not to go with that. So plasmapheresis, you are removing plasma from the patient and you are giving the new part of it. So these are the indication. Again, divided into toxicological and non-toxicological part. Then non-toxicological, again divided into system. So obviously for GBS, because you will remove the plasma, because antibody, wherever there is an autoimmune part, you can write that part and you can escape. Then barbiturate poisoning. So remember, I think you know toxicology part, that you need to know the toxicology syndromes: sympathetic, parasympathetic, CNS depressant, RS depressant. So this comes under CNS plus RS depressant. So these are the things. So major thing which you need to remember is it's an acidic thing. You have to alkalize the urine and you have to excrete. Nothing less, nothing more. If there is seizure, go with symptomatic treatment with benzodiazepine. Then paracetamol poisoning, make sure you draw this Ramak-Matthew diagram. Okay, so remember, x-axis is time, y-axis is mg per ml. Okay, 10 to the power minus 6 grams per ml, and 50 in the type of 50 we have divided it. Then at 200 we have the possible toxicity dose, and more than 100 we have probable toxicity line. So this is to plan for NSC administration. Okay, though we give NSC to all for theoretical purpose, to gain marks, to fetch marks, we write this. Okay, so there are 4 stages. Remember, stage 1, stage 4. Stage 1 is there is nothing specific. Stage 4 is either dying or is recovering. That's it. Stage 2 is that we will have some sort of pain or hepatomegaly. Stage 3 is with complication. Know this and go. You can write on your own. Then again, initial ABC will go. Then antidote is NSC. Make sure you remember the drugs. So how I remember is ulta it is like a circle. So 50, 100, next 150. Then this is with 15. This you have to remember. Okay. So what are the indications? So that I have discussed. If it's an advanced, and you have to go for liver transplant and OP poisoning also. Second year, third year, and also fourth year. I don't know what else to I mean, how important it is in and out. Even this, they have asked for 10 marker in medicine only. Okay, so I cannot say this is not an that important topic, but it's an important one for sure. So study this part. So again, same thing. Management, I'll go. It's a clinical diagnosis. Then you need to start with atropine, 2 ml. Again, signs of atropinization. Then again, you need to treat symptomatic management, and again divide it into a moderate, severe, mild. Here, atropine itself is enough. Based on the duration, you can ask paradox sign. But if it's severe, then you might also have seizures. So you can give benzodiazepine. This is in total what I want. In total, what I wanted to say about the whole medicine thing. See, it's basically you might feel it's just 82 pages, but see, a day before exam you should know what you should not learn than things what you should learn. If you sit and study about the pathogenesis of some random disease which is being asked for 3 markers just for one time, if you wanted to study it before, I think you would have studied that. Not now. This is not the time. Then don't come and say, we were studying till 3 o'clock, 4 o'clock, we couldn't wake up. No, it's not required. If you have a material which is revisable, you can definitely finish it. So, a day before, so for example, you know this, all these things, then you know what to plan. Obviously, these are things which even I don't, or even teachers don't know, because even the people who prepare paper, they see it on their mind. What do they get? They just give it part. So always, whenever after finishing your paper, make sure you are think you are a professor or an examiner and start evaluating, because nobody will write for 3 hours, and if you are writing for 3 hours, you are already out of game. So whenever you are having time, you need to go through your paper. You need to think what you should add flow, add more diagrams. For example, for DKA or HHS, don't just write the management part. Draw that human, draw that IV line, because it's given in Davidson. You need to show that you are reading Davidson at the end. Though you have read other books, if you show that you are reading standard books, at the end it's this word avoids audacity. So you need to show what you are doing. That's how the world runs. So make sure you go with that part. And why before starting, so if you are starting now, make sure you know the basics of each chapter, so that you can dwell upon the chapter, and you have some basic concepts, so that you don't get shaken when they ask you bouncers are supposed to come and should come. Otherwise, what is the point of having exam? Bouncers will come. I'm not saying there will be no bouncers. Bouncers will come, and it should come. But how do you manage the bouncers with the knowledge which you have studied is something is left to you, which even I cannot. Which even I cannot discuss. So next time we'll come with paper 2. Make sure you study all these things related to paper 1, so that you have a sound knowledge and you're confident. At the end, you should have a confidence to go to the exam and write the exam and come back. That's the aim. Aim is to sleep peacefully a day before exam. Though it's an argument, and even I don't get proper sleep, saying what might be asked, what might not be asked. That's all true. But you should have that confidence saying yes. At any point of time, if they give exam, I should be able to pass with the knowledge of whatever revisable material I have. If you have that, definitely you can go and do the revision material. So make sure you study these chapters and go a day before exam. This is what paper 1 is being asked. And also be happy. Before 2018, if I'm not wrong, I think the whole chapter was there. The whole medicine there was no partition like this. Everything is there under medicine paper 1, everything is there under medicine paper 2. So thank God that you have proper classification now, and they follow some kind of pattern. For example, CVS, heart failure and MI, even they had asked about last time, they asked about conducting system of heart. But if you come and argue with me, sir, you are not told about this part. See, that's something which I've learned in first year. Not even in first year. I think even in 11th standard physiology part, when you are talking about CVS, that's something SA node, then it goes to AV node, then it goes to Perkins, then that's something which you know. So there are things which you will study and which you won't study. But what is the game is how will you make that 3 hours utilizable and efficient? That's the game. It's not, and what you revise a day before exam. So make sure you revise it properly. Make sure you have a proper idea of what you are reading. Then go to an exam. That's it. I wish you the best. Make use of these notes. Thank you.